welcome. I'm Matthew Goodwin. I'm a spine surgeon at Washington University in St. Louis.
And I'm Wende Gibbs. I'm a neuroradiologist at Barrow Neurological Institute in Phoenix.
So today I think we're going to talk about radiology reports. And this is such a big topic that we wanted to make this video, hopefully to help and not confuse more. One of the things I want to start with is nowadays, it's very different than it was even 5 or 10 years ago. Nowadays, you put a report in on an MRI, let's say, and the patient seems to see it right away. And then they come into my office at whatever point, and they might even have it on their phone, or they don't even print them much anymore. And they'll say, what does this mean? And sometimes they want to go through it all. And one of the struggles we have, or I've had, is explaining to a patient that the report, in my view, I don't want to step on any toes here, is part of their visit, essentially, right? It's part of the puzzle. And so I would say there's the imaging and the reports. There's the examination. There's the history. And there might be other stuff. There might be nerve testing. But there's all things that we're going to do, and we got to put them all together. And I oftentimes have to tell my patients about the many papers that are out there where people have, as they get older, lots of degenerative changes, and they're asymptomatic people. They don't have any symptoms. And so when you're dictating a report or writing a report, let's say it's an MRI of the spine, what do you want the patient to do with that now that you know, because it's not written for the patient, right? It's just now that the patient sees it, right? I write my note for me in the record, and the patient sees it, and that's fine. What do you want them to think about your report when they read it, or what should they know about it when they read it?
Yeah, that's a very big issue in radiology. It actually has been for probably 5 or 10 years, as reports have been getting out into the charts and into the patient's hands sooner, rather than going to the primary care doctor or whoever ordered the study. And it's kind of a struggle for radiology because the language that we might use in our reports might be aimed at our surgeon colleagues or our oncology colleagues or some other specialist that uses terminology that maybe, the layperson wouldn't know.
Right.
So that's one issue. Who am I writing my report for? I think the movement lately has been to change our reports a little bit because the patients also need to know this information.
Oh, interesting.
If we are able to create a report that a patient can understand in language that we all use every day, I always kind of do that. I try to use language that I would use with my parents, my friends, when I can. Sometimes there is special terminology. You can't do that. But if we can, we want to make it accessible to everyone. We want to make it understandable to our colleagues who ordered it, to the patients, to different specialists who might use different language.
Interesting.
As you can imagine, that's hard to do.
Yeah.
Because every specialty uses different language and different terminology. And so we talk a lot about artificial intelligence and machine learning and stuff these days. I am a bit of a skeptic myself. I don't think it's going to help in a lot of ways, but in reporting, there are attempts to make one report, the report I dictate, it will translate it into something that you could use as a surgeon, maybe a certain set of words, a certain language.
Shorter.
or
Very short.
or that that might be aimed at somebody, just anybody, your mother, your friend, anybody like that, into different languages. So that's the kind of progress we're making there. That's taking time. It's something very new, and we want to make sure that we get it right because it's people's health at stake here. We want to make sure the information is accurate.
Right. And
in a form that you can still use.
Right.
But whenever we can, yes, the patients see this. Oftentimes, actually, I'll tell you a story. This happened to me. Before I went to medical school, I had to get a CT of my neck. I had an injury, and I had a thyroid nodule. And I got my report, but I think it said mass. I can't remember if it said mass or nodule. But anyway, I thought, wow, what is
lesion.
this?
Could have said lesion, my favorite word.
Yes, it was a scary thing for me because I knew nothing about medicine. And I went to my primary care doctor, and I said, my report says I have this. She said, oh, no, don't worry about it. I'm like, well, but it said in the report that I have this.
Yeah.
And it was a little bit scary to me, and so she explained it, and then it was fine. And that's to kind of say, when patients do get their reports, I would, try to get it to the doctor that ordered it right away, have them explain it. Sometimes radiologist can explain it if you need, but usually it's best if the person who ordered it is the one to explain it. Yeah.
Yeah, so you mentioned having a nodular. I mean, so that's the next, I obviously see spinal tumors, which means I see a lot of lesions. You know, I get sent a lot of things that are an abnormality in the scan, and patients usually come with the report, and it varies what is said about something that may or may not be worrisome, right? And so I like to oftentimes go over the imaging with them, tell them what I think, and go over the report, because sometimes the report will say, sometimes it will be a benign lesion, so a lesion that's not cancerous, and it may be a benign lesion that's common. So you might see in the report, looks like a hemangioma, and you know, for the patients, I would say that's, you know, very common, you know, 10% of people or so. So much so that I even tell them, sometimes it comes up and somebody will say, hemangioma cannot rule out, and then might list things like sarcoma. And then the patient comes in having Googled it saying, is this what I have? I have sarcoma, you know, and then we're off to the races. And I tell patients, I say, look, some radiologists don't even mention the hemangiomas because they're so common, right? Some of them just leave it out. If they're typical hemangiomas, sometimes they're not even there because they're so common. And so I try to explain to the patient, or I try to get them off the ledge early in the visit, if it's a lesion, and say, look, you have a thing. You know, you have something that may or may not be abnormal, but on the image, it looks a little different. And then we kind of go, depending on what it is, we go down the path of saying, you know, kind of working towards figuring out what it is, which might be very easy, or might need a biopsy, or might need more. But there's definitely this moment of discussing and kind of getting them down off the ledge. And so I don't know, I like that patients are, get the reports. I like that they're involved in their care. I actually like usually when they look stuff up, because as long as they're not freaking out in general, usually they know a little more, and they like doing that. They want to know about their health. But I don't know that I have a good answer for helping them through that process when it says cannot rule out, lists a bunch of stuff, you know, because I'd probably see that and go, cannot rule out what?
Yeah, it's hard. So I think it's not every radiologist does that.
Yeah,
I would say I don't use even the word lesion myself, because that's something most people don't know what that means. It's kind of meaningless in a way. Right. It's just maybe a way of not saying, you don't want to say it's a tumor or something. You have to say it's something, like you said. You said a thing.
Right.
So maybe lesion and thing are similar, but something that...
Well, that's literally what I say. That's where I start. I say you have a thing.
People know what thing is.
And it could be a lot of different, and maybe nothing. It may be a nothing. It might not even be a thing.
And I always, you know, if you have a trained subspecialist, maybe they will more likely give you an answer, a little bit more of an answer of what this thing is, and not just say thing. But something that patients don't always know, and maybe you don't know this either, is that radiologists, when they're specialized, like neuro, actually go to school as long as spine surgeons. Did you know that? So we also learn how to correlate some of the clinical information, if we have it, with the imaging. And we, you know, it's a different specialty, but also doctors. So usually we are able to come up with more than just thing.
Yeah, that's interesting, because that is...
And so we might make an attempt to guess what it is, but it's best when you and I talk about the case, because we don't always have the history.
Yep.
And if we do know from you, then we can tell the patient exactly what they have between the two of us.
That's so interesting you say that, because I am surprised when I see that there's the radiologist has either read the last couple notes, or they've talked to somebody and have that information. Because I would say I personally don't expect that. Do you know what I mean? Because and this comes up with patients sometimes, where and this gets into a whole other issue of patients saying to me, how come this wasn't seen when it was there on whatever and it didn't get read? And usually when you go back and look, usually you go, gosh, I don't, you know, because I'll look at it with them and go, gosh, I don't know. I'm not sure anyone would see that. You know what I mean? I'm not sure it is there. Sometimes it's there, but sometimes it has nothing to do with why they're getting the image, and it's small and you can't tell. And so that's a different area, where there's probably a whole bunch of things to unpack. I don't know if, in terms of AI or catching things that are outside the field or whatever.
Well, I guess it depends, because it also could be what you mentioned first about the hemangiomas. So I know that's not going to matter to the patient.
Right.
Because if I know even a little bit of the history,
Right.
and I see it, and I know it's not related to what they're getting the study for, I'm probably not going to mention it.
Right.
For that reason, it's not important. We need to keep the report shorter and to the point of what question are you asking that I can answer
Right.
from this person's study. But there's also, there's different levels of training. You're going to get a different report from a community radiologist who didn't do a fellowship, somebody who did 2 years neuro fellowship, or something else. So people are people, doctors are people. It's different.
Right.
There's
Right.
different
Right.
opinions about what's important. There's different, I guess, threshold of what you call, and
Right.
maybe it was a late night for that person. They missed. That happens too.
Right.
Hopefully it wasn't important though. I mean, hopefully it wasn't something missed that was
Right.
vital
Right.
to that. So, and all those things happen, and I think people understand that it's hard. It's a hard thing, but knowing that doctors are human too, I think is good for everybody to realize
that's
that we
something
do our best. But I don't know if that answers your question or if that addresses that issue, that story. But
Well, it's interesting because patients always want to know the timing issue. Why didn't I get? I mean, it's the same thing, Russ. Why didn't someone do an MRI earlier?
Yeah.
And I'll have to explain. And this is as good anywhere to mention this. That back pain is so common. That you can't. That's a very common thing that somebody has a lesion, has a tumor, and they had pain, and they might say, "How come it was 6 months, 9 months before I got an MRI? I did therapy. And I have to explain, it's so overwhelmingly common to have back pain that I don't think, there probably aren't enough scanners in the world to MRI everybody. I don't know that it would work, it just doesn't. And so and I think people understand that, but that's also an area that can be difficult.
I'll address that. Can I say something else
Yeah,
about that?
please.
That is really the role of radiology. So because everybody has back pain, really our role is not to say all the little levels of whatever.
Right.
We're finding something besides that.
Right.
I'm looking for the tumor or the
Right.
fracture because of osteoporosis or something else, systemic disease, something in the bone marrow. That's my value because everybody's got all the degenerative changes. So I
Right.
would not list all those because
Right.
they don't matter unless you're looking for them.
So the take home from today for reading your radiology report, yes, okay to read it.
Yes.
People, they're going to read it anyway, I guess,
But
right?
go to you right away.
But have a plan. Don't freak out.
Yes.
If it says cannot rule out stuff, take that with some grain of salt until you know more,
Yeah.
because it could be a long list of stuff that it's probably not. What else are we leaving out?
There was a lot there. Doctors are human,
Doctors are human. That's a good one, right? Right.
and we're doing our best.
And we're doing our best. That's
All
right.
doing our
That's
best.
a good one.
And we'll work together to take care of the patients.
That's a good one.
Like that?
I like it. Perfect. Hopefully that adds some clarity to when you open up and see your reports. And yeah, thanks for joining.
All right, thanks.
Thanks, everyone.